So welcome everyone who's joining us live. This is one of a series of webinars on behalf of the World Federation of Neurosurgeons, Neurosurgical Society's Young Neurosurgeons Forum. And today we have the privilege of talking with Dr. Kostas Fountas about the diagnostic approach and preoperative evaluation of medically refractory epilepsy of temporal or extratemporal origin. Dr. Fountas is a professor of neurosurgery at the University Hospital of Larissa, which is University of Thessaly in Greece. He earned his medical degree from the University of Athens, Greece, and completed his neurosurgical training at the Medical Center of Central Georgia and the Medical College of Georgia in Augusta, Georgia, USA. So double Georgia. He joined the University of Thessaly in Larissa, Greece in 2007. And he's been the head of the Department of Neurosurgery at that hospital since 2009. His scientific interests are focused on epilepsy surgery, neuro-oncology, functional imaging, and electrophysiology. He has contributed to more than 180 publications in peer-reviewed journals, as well as several chapters in textbooks. So, Professor Fountas, thank you for joining us today, and we're very excited to hear about your talk.
Thank you, Faith. I would like to start by saying good morning or good afternoon or good evening, depending on what time zone everybody is. I would like to thank you, Faith, for all your assistance, and also I would like to thank Dr. Kostas for his kind invitation and for giving me the opportunity to share with you some of my thoughts on how we manage these patients with medically refractory or medically intractable epilepsy. So as you can see from the my first slide, there is an oxymoron there on the title of my presentation, because I'm talking about temporal, but also about extratemporal epilepsy. And actually, I want to emphasize on epilepsy of temporal origin, because this is significantly more common than extratemporal epilepsies. However, I'm going to just cover other epilepsies also, so whatever I say about temporal epilepsy is pretty much applicable for epilepsies of extratemporal origin. So to give you an idea where I'm coming from, Larissa is in the heart of the Greek mainland, approximately 200 miles north of Athens, approximately 100 miles south of Thessaloniki, and the time zone is 1 o'clock in the afternoon, so you can have an idea. The weather today is really cloudy here, and with no further delay, I would like to start with my presentation. These are my financial relationships, which I think that will not affect in any way my presentation to you today. I'm not going to discuss about any products that we are using in epilepsy surgery coming from these two companies that I'm related to. Epilepsy is quite common disease. It affects approximately 1%. Let me just advance that. That affects approximately 1% of the general population. There is some geographical and racial variation around the world, but if somebody does the math, it affects approximately 2 million people in the United States. So we know that it has been well described that approximately 1/3 of the patients with epilepsy develop at some point something that we call medically refractory epilepsy or medically intractable epilepsy. There is a pretty nice and accurate description of what we call medically refractory epilepsy in a paper quoted by Kwan and his co-workers. So when we discuss about medically refractory epilepsy, we refer to a condition that when we administer at least 2 major anticonvulsant medications in any combination and there is no response, then we define that form of epilepsy as medically intractable. So in the US, it affects approximately 400 to 600,000 people. And these people may be suitable, or at least half of them may be suitable for surgical treatment of their epilepsies. And as you may see, we know quite well that epilepsy is a surgically amenable disease. And you remember that previous number that I showed you, that it affects in the form of medically refractory approximately 500,000 people. And despite that, there are only 1,500 epilepsy cases performed on an annual basis in the US. So you can understand that there is a tremendous mismatch between the surgical candidates and the patients who are undergoing surgery. So there is no question that there is significant underutilization of epilepsy surgery in the US. I assume it's the same in Europe. And I think that it's even worse in other parts of the world. Why? I think that we need to discuss that if we do have time immediately after my presentation, but it's quite interesting to see what are the factors that predispose to that underutilization of epilepsy surgery. So is it truly epilepsy a surgically amenable disease? I think that this paper, which is a classical paper, was published approximately 20 years ago and was coming from Canada, actually taking advantage of the medical system, which is a socialized medical system in Canada, compared the surgical management of patients with temporal epilepsy versus conservative management. And I think that you can see the differences there. The seizure freedom in the surgical group was 64% versus only 8% in the conservative group. Also, the decrease in the seizure frequency was significantly higher in that surgical group, 100%, versus 34%. And the most interesting part, I think, of this study was the definite improvement of the quality of life of epileptic patients in the surgical group, which is highly questionable in the group with conservative pharmacological treatment. Also, another parameter that I think that needs to be brought into the equation is that of the cost of the total treatment, the overall cost of treatment. And I think that this is significantly lower in the surgical group compared to the pharmacological group. So this is a really strong proof that surgical treatment is superior to any kind of medical or pharmacological treatment in regard to temporal epilepsy. And this is a prospective double-blinded study. I think that it's one of the rare occasions in neurosurgery that we do have so strong evidence that surgical treatment is superior to any kind of medical treatment. Now, the commonest form of focal epilepsy is that of the temporal origin. It affects approximately 75% of cases of focal epilepsy. And we know that approximately 1/3 to half of these patients will develop a form of intractable disease, intractable epilepsy. So this is the major part of our practice, temporal cases, epilepsy of temporal origin. We usually divide the causes and the cases in two large groups, those that we can identify a structural lesion on the preoperative imaging studies, mostly MRI, and we call these lesional cases, and those cases that we cannot identify an underlying pathology on the imaging studies, and we call it non-lesional cases. Now, I think that if you just try to identify what is the cause of having no structural abnormalities in these non-lesional cases, I think that most of the time we cannot identify because our imaging ability is not high enough. Having said that, I think that with the employment of 3 and mostly 7 Tesla MRI in these patients, in the preoperative evaluation of these patients, we'll be able to significantly decrease the number of non-lesional cases and increase the number of lesional cases. What are the causes of lesional cases? You can see a list of, on the left side of your screen, temporal lobe tumors, any kind of tumors, most of the time low-grade tumors, such as DNETs or gangliogliomas or low-grade astrocytomas. Of course, vascular malformations, arteriovenous malformations, cavernomas or DVAs. Mesial temporal sclerosis, especially when we talk about adult populations, this is one of the most common causes of epilepsy of temporal origin. And also neuronal migration disorders with the most prominent focal cortical dysplasia, which may not be that focal, but we'll discuss that especially during the next week's presentation with the surgical management. And more rarely, infections such as herpetic encephalitis or other infections that have some kind of predisposement to the temporal lobe, and trauma. So I've already discussed about the non-lesional cases that with the employment of higher strength MRIs will be able to just shrink that percentage of non-lesional cases. And pretty much the same are applicable for frontal lobe epilepsy. It's significantly less frequent than temporal epilepsy. You can see that affects approximately 10 to 20% of the focal cases, and is definitely less studied than temporal epilepsy. And there are some unique characteristics in frontal lobe epilepsy. Most of the time, we do have some significantly rapid seizure spread in these patients, and this is mostly due to the frontal bisynchrony that occurs in these patients. So it's slightly more difficult to deal with these patients and identify the epileptogenic focus or the epileptogenic network in these patients compared to the patients suffering epilepsy of temporal origin. Again, the same kind of pathology, lesional and non-lesional cases, and as somebody could suspect, the non-lesional cases most probably will decrease within the next few years with employment of 3 or 7 TMRIs. And again, the pathology is pretty much the same. I don't have to repeat everything. Big categories, mostly injuries or low-grade tumors or some kind of post-traumatic gliosis, and of course, infections and vascular pathology. Occipital and parietal lobe epilepsy, you can see that the numbers are significantly lower here. The occipital is approximately 8% of the cases, and the parietal is even less rare, 1.4%, as you may see. Of course, we'll know less in these epilepsies because these are more rare cases, and we don't do that many surgical cases with epilepsy of occipital or parietal origin. There are again some unique characteristics, especially with the occipital form. There are some visual auras or some phosphine seizures, but I think that both of these are, occipital and parietal, are mostly focal seizure epilepsies with rare secondary generalizations. And again, the pathology for both occipital and parietal is pretty much the same as with the other two forms that we've already discussed, the temporal and the frontal. So what is the purpose of epilepsy surgery? What is the main doctrine behind the epilepsy surgery? Is to identify by either employing non-invasive or invasive methodologies the epileptogenic networks and possibly try to resect or modify, neuromodulate if you prefer, these epileptogenic networks. And actually we can do that with two different methodologies. One is the resection of this area or areas, and the other one is the modification of the function of this area. So non-resective methods. And always the goal is to accomplish seizure freedom and improve the patient's functional status and the quality of life. Now, the last few decades, there is some kind of shift from the epileptogenic focus concept to the epileptogenic network concept. So we were discussing 2 or 3 decades ago that we are trying to identify the focus and remove that area, keeping in mind that we were trying to keep that area as small, as limited as we could. And nowadays, we believe that this is not true, that there are significantly more extensive networks. And what we're trying to do is just resect or intervene and modify some nodes in these epileptogenic networks. So, how do we approach these patients? How do we work them up preoperatively, and how can we decide which patient is a good candidate, surgical candidate, or which patient is not? I think that this is something that is not solely neurosurgeons' work, but I think that us we consider ourselves not as brain cutters, but as neuroscientists, we need to just be actively involved in that preoperative evaluation of these patients and collaborate with either the epileptologist or the neuroradiologist or the neuropathologist and so on. So we traditionally divide these methodologies for the preoperative evaluation in two large groups: phase 1, which includes non-invasive methods, and phase 2, which includes mostly invasive, either minor or more invasive methodologies. And let's start and try to identify what each one of these methodologies can contribute to the evaluation of these patients, starting with the neurological examination and the seizure semiology of these patients. So the vast majority of these patients have a normal neurological examination. However, we can just learn a lot about the identification of the pattern of the epilepsy by just discussing with the patient or the patient's relatives, and try to see any seizure activity on a video. And I think that we can learn a lot about discussing about the auras of the patient, especially in temporal cases, in epilepsies of temporal origin. The auras are quite characteristic. There are some kind of olfactory or gustatory hallucinations, as you may see. There are automatisms. Most of the time there are some mouth or hand stereotyped automatisms, oral alimentary automatisms with their lips. And there are rarely some generalization, some secondary generalization, approximately 30 to 40% of these cases. Now, you need to keep in mind when you go through the patient's seizure semiology, or when you discuss with your epileptologist, that each patient may have more than one type of seizures. And this is really crucial to know it beforehand, so you'll be able to identify properly if there are two different networks, two different epileptogenic foci in this specific patient. So what is the next method that we can offer to these patients? How can we evaluate these patients? Interictal EEG, regular surface EEG, can provide some information, but as you may see, in approximately 1/3 of these cases in patients with medically refractory epilepsy, this is absolutely normal. So in the majority of these cases, we get non-specific findings, but rarely can get some information about lateralization of the pathology. In other words, we can say that, okay, it seems that the epileptogenic network is located on the left or on the right hemisphere of the patient. I think that can provide some information, and actually regular interictal EEG can give us an idea of if we need something more specific and we need to pay attention on specific anatomical area in these patients. What about high density EEG? This is something that is coming up. We can use either 256 contacts or 512 contacts and can have some more accurate, spatially accurate information about the electrical activity of the patient's brain. In the advantages of this methodology, which is not that routinely employed in the management of these patients, something that is considered a research tool nowadays, it's a non-invasive method. As you may understand, the spatial resolution is quite high compared to the 32 or the 64 contact EEG. It is also applicable in children, which is quite important, and also can provide some information about cortical mapping. This is something that we will discuss more extensively towards the end of my today's presentation. The disadvantage of these methods are the high cost of purchasing the equipment, and also the fact that it's considered an experimental method, and the clinical experience we have with that methodology is still limited. Next method is the video EEG, which can provide information about the electrographic activity of the brain during an ictal event, during a seizure phenomenon, and also can couple the electrical activity to the clinical activity that we see during a seizure. So what we usually do is we just hook the patient and we just monitor all the time. It's like having a big brother into the patient's room, and we just record all the electrographic activity for 24, 48, or 72 hours. The goal in that recording is to record at least 2 or 3 typical seizures of the patient, so we can identify where these seizures are coming from, if we can identify that network or that anatomical area that there is some kind of abnormal electrographic activity. So you can see that can provide significant information. They can, in the vast majority of cases, the Ictal and the Interictal video EEG can guide us to the epileptogenic focus or to the epileptogenic network. And even in those cases that we do have significant or non-accurate information, can still provide some information about further evaluation of these patients and can guide us toward that direction. What about imaging modalities in these patients? Most of the time we employ MRI, conventional MRI, but we need, even for a conventional MRI, a specific epilepsy protocol. You can see that the slice thickness needs to be anywhere from 5 millimeters to 1 millimeters, and we need to have coronal, oblique, and axial views, of course. We need to have flare, T2, and proton density. And this is something that varies from center to center and from imaging modality to imaging modality, but I think that it's really important to have a detailed imaging of the hippocampus area, and we can have some kind of information about the quality and the quantitative analysis of the hippocampal structure. And of course, if there is any kind of suspicion of underlying pathology, tumor, or infection, the administration of gadolinium or any other kind of contrast enhancing material needs to be taken into consideration. This imaging protocol, this is what we employ in my institution, varies from patient's age group to another age group. So it's a different protocol for a patient who's less than 2 years old, different for a patient who's anywhere from 2 to 50 years, and of course, a different protocol for patients older than 50 years, although this is a minority of the patients with medically-intractable epilepsy. I'm not going to spend any more time describing these protocols because I think that is definitely beyond the scope of this presentation today. And also we need more experienced people, neuroradiologists, to just go get us through that, the details of these protocols. We need to identify the areas of the amygdala and the hippocampus, as we discussed, and we usually do that by having the, in mind that these areas, these anatomical areas, need to be symmetrical on both sides. So if there is any kind of asymmetry, then we can start digging there and we can see if there is any kind of gliosis, any kind of volume loss of the hippocampus, and so on. Also, hippocampus is not the only area of focusing and reading these studies. Also, the temporal neocortex is of importance. As you may see, we may identify some kind of atrophy, or we may identify some ill definition between gray and white matter. And also the size of the temporal horn may play a role and may provide some important information. So if there is a dilatation of the temporal horn, this may be an indirect indication for some kind of atrophy of the hippocampus or the amygdala on the same side. And there are areas, extratemporal areas, in temporal cases that are of special interest, as the fornix or the mammillary bodies. Occasionally you can see atrophy in both of these structures, or the basal ganglia, the thalamus or the caudate nucleus. They have described that there is some kind of atrophy in cases of epilepsy of temporal origin. And also we need to just check and see what is the texture and what is the size, the volume of the entorhinal cortex in these cases. So what are the usual causes of epilepsy? The most common one is that of mesial temporal sclerosis. You can see a characteristic case with dilatation of the temporal horn of the ipsilateral lateral ventricle here, and also some decrease in the volume of the hippocampus on the same patient, as you may see. And different qualities here with different imaging on an MRI, different sequences. Also, glial tumors, as we discussed, the vast majority of these tumors, especially in younger patients, are low-grade gliomas, either gangliogliomas or DNETs, or a pilocytic astrocytoma, or an oligodendroglioma, grade 1 or grade 2. Vascular pathology may be responsible for temporal lobe epilepsy as an AVM, or a cavernous malformation of the temporal lobe, especially of the mesial structures of the temporal lobe, infections with some kind of predilection for the temporal lobe, such as herpetic encephalitis. And you need to keep in mind that in approximately 1/5 of the cases of temporal lobe epilepsy, you may end up having some kind of dual pathology. As in this case, you can see that there is some kind of hippocampal sclerosis in this case. You can see that there is some gliosis of the hippocampus on one side, but on the same patient, there are some bilateral heterotopias in the periventricular area. You can identify those on the MRI, on the coronal image with a black arrow here. You can identify these heterotopias. So you need to keep that in mind, because you may end up removing the temporal lobe and the mesial temporal structures in this patient, and the patient may still have seizure because of this other pathology which has not been apparently addressed in the first surgery. And this is quite common in temporal cases, approximately 1/5 of the patients, so keep that in mind. What about advanced MR methodologies? Do we use any? Of course, we use Proton MR-spectroscopy, we use diffusion tensor imaging, DTIs, we use something that we call cortical unfolding, or if you prefer, the pancake technique. And also we use quite routinely the volumetry of the hippocampus, so we'll have some kind of quantification of that hippocampal atrophy that we are discussing about previously. So just a brief overview of the Proton MR spectroscopy. I assume that most of you are quite familiar with the method. It's an MR-based method that non-invasively can provide some information about certain metabolites on a certain area of the brain or on the whole hemisphere of the brain. We do have the ability to perform either single voxel studying or a multi-voxel studying and identify the metabolic profile of a certain anatomical area. The markers that we usually play and study are the choline, the creatine, and N-acetyl aspartame. And actually, we perform all this metabolic ratio, which can provide some important information about the metabolic profile and indirectly identify areas with structural or functional abnormalities. So we always do that by making some kind of comparison between the right and the left side, and any kind of abnormality or asymmetry, again, as on imaging, can provide significant information and further guide us towards what side the pathology is. And of course, there are certain areas that present certain interest, especially in epilepsies of temporal origin. We want, besides the mesial temporal structures, to examine the temporal poles and also the temporal neocortex, because this can be part of the pathology. We published a few years ago, I think it was like 8 years ago, that in patients with mesial structure abnormality, there was also some kind of abnormality on the temporal pole of this patient. So this is quite important piece of information to know beforehand, before doing the surgical planning and actually doing the actual surgical removal, the resection of the pathology, to be able to identify if there are any other areas with abnormality, either structural or functional, that need to be taken into consideration and possibly be removed. What about that unfolding, the pancake technique? The pancake technique is something that is MR-based, and as you can see, we can take the cerebral cortex and unfold it like a pancake. This is something that was firstly described by a neuroradiologist in the University of Bonn, Professor Urbach, and it has become really popular among neuroradiologists around the world, and can provide significant information about tiny pathology, tiny microstructural changes in the cortex. It's a valuable tool, especially if the underlying pathology on a patient is some kind of neuronal microvisual disorder, especially focal cortical dysplasia. So this is one of the techniques that may decrease the number of non-lesional cases in the future that we were discussing a few minutes ago. So by employing all these electrophysiological studies and also the imaging studies as the MRI, we go to an algorithm that we do have patients that there is some kind of agreement between the electrophysiological studies and the imaging studies. And I think these cases, if there is concordance between the findings of these studies and we can identify accurately the epileptogenic network, then we can move to a surgical resection in these patients. Now, what about in these cases that there is no agreement between the electrophysiological studies and the imaging studies? Apparently, we cannot intervene, and we need to just further evaluate this patient and explore and try to identify more accurately the epileptogenic network. And the same is applicable to the non-lesional cases where we cannot identify a structural abnormality on the performed imaging studies, and we need to further evaluate these patients with non-invasive methodologies. What kind of methodologies? Methodologies such as the Ictal SPECT or the SISCOM, which is practically the superimposition of the Ictal data that we have on the MRI. So what we want to do is we want to identify those areas that are metabolically active during a seizure event and superimpose all this data on the MRI, increasing thus the spatial resolution of this methodology. So in these cases, we can have a confirmation of an epileptogenic focus or an epileptogenic network in lesional cases, or identify those abnormal networks in non-lesional cases. The major disadvantage of this method is that although it can provide significant information, it requires highly trained nursing staff, and also depending on the country you are practicing, you may end up requiring a nuclear medicine physician. And if you keep in mind that the patient may have seizures during the night, during the video EEG monitoring, or after hours, then this may be a potential problem to have your nuclear medicine physician there all the time waiting for the patient to have some kind of seizure. So these are the major disadvantages of that. You can see that the diagnostic accuracy of the method, especially in temporal cases, is anywhere from 70 to 100%, and I think nowadays with the involvement of the methodology, the SISCOM methodology, the actual number is closer to the 100% than to the 70%. In the extratemporal cases where we really need this to use these methods, the accuracy is lower, as you may see, anywhere from 30 to 60%. But keep in mind that this accuracy can be significantly increased if we use the SISCOM modality with PET and increase thus the sensitivity and the accuracy of both methodologies, which is the next tool that we can use for evaluating these patients. The PET scan or the PET CT or the PET MRI, we use several different metabolites that we can study. You can see we can have traced water, traced glucose, or methionine, or any kind of modality that you can use. If you start checking for research protocols, they use several different substances and trace them with a PET or a PET MRI or a PET CT. You can see that can provide significant information, but the disadvantage of the method is that, again, requires highly trained nursing staff and, of course, expensive equipment. You need to have a PET CT or a PET MRI in your institution, your facility, to be able to use that, and specially trained physicians too. The diagnostic accuracy in extratemporal cases, where we need that methodology more, is anywhere from 40 to 80%. However, in diagnostic, the diagnostic value of this modality of the PET scan is less in temporal cases, but keep in mind that in temporal cases, in the vast majority of these cases, we don't really need the method of the PET CT or PET MRI to identify the epileptogenic focus. Even when we employ all these methods, we may end up in cases that we cannot still identify the epileptogenic network, the epileptogenic focus. And in these cases, the next tool that we can use is a more powerful tool, that of the magnetoencephalography. And this is based on the principle that every kind of electric current creates a magnetic field. And if we can record that magnetic field and changes of that magnetic field, we may get significant information about abnormal electrical activity of the brain, identifying thus any kind of epileptogenic focus or epileptogenic network. And you can see that we can get all this magnetoencephalographic information and superimpose it on an MRI, increasing thus the spatial accuracy of this electrophysiological method, which now becomes a hybrid method because it's an electrophysiological and an imaging methodology. So this is what we call MSI, magnetic source imaging, where we do have the magnetoencephalographic data superimposed on the MRI, and then this method can provide some information and identify where there is some kind of abnormality of that magnetic field, consequently of the electrical field. And you can see that we can have different patterns. We can have a very focal pattern, which is, we love it because that is a strong indication that there is some kind of abnormality, that the underlying pathology is right here. And if we resect that, possibly we can have the patient being seizure free. We can have a regional pattern, which can give us some idea where the epileptogenic activity is located. But we can have some something that is really non-informative, as in these cases, with multiple areas that there is some kind of question where the seizure is coming from, or something like that, with scatter activity, abnormal activity in the brain, which is not helpful at all in this in the localization of these patients. So the diagnostic accuracy from the literature, anywhere from 60 to 70% in temporal cases, lower in extratemporal cases, around 40–45%. The major disadvantage of this method is the quite high cost of the equipment, is approximately $1 million US. So, and also it requires special personnel, specially trained personnel. But you need to keep in mind that when you compare this method to all the other non-invasive methods that I showed you, such as the fMRI or the PET that we were discussing, or the SPECT and the SISCOM, the spatial and the temporal accuracy of this methodology is higher than any other of these methodologies. So the magnetoencephalography provides significant information, but on the other hand, quite expensive piece of equipment to have it in your facility. So by employing all these non-invasive methods, we are to a point that we do have patients that there is agreement between all these and nice identification of the epileptogenic network, and we can perform a surgical intervention, either resective or non-resective surgery. And there is still a small percentage of cases that there is either a disagreement between all these employed methods in their findings, or we cannot identify pathology still. And in these cases, then we need to move to the next phase, to the invasive evaluation of these patients. So we need to perform some kind of more informative, more meticulous, if you prefer, electroencephalographic study in these patients. And how can we accomplish that? By just employing depth electrodes or subdural strip and or grid electrodes, subdural electrodes, for having some kind of invasive EEG. And also by doing that, we can at the same time perform some kind of extraoperative stimulation for mapping purposes, cortical and subcortical mapping purposes, so we can identify the eloquency of the areas that are involved in the seizure activity, in the epileptogenic activity, and this can provide significant information if we can safely remove these areas or not. Let's go and see in brief this invasive EEG modality. So we were discussing about depth electrodes. We can insert those either stereotactically with frame-based or non-frame systems. I think that the accuracy is comparable, definitely nowadays with frameless systems, but there are surgeons that still prefer to do that procedure with a frame-based stereotactic system. You can see the Lexel system here, but there are several systems in the market, and you can have, it's definitely surgeons' preference what kind of system they're going to use. Practically, and when we talk about temporal cases, there are two ways to implant your electrodes, your depth electrodes, and cover the mesial temporal structures. This is the occipito-temporal way, where we go from the cortex of the occipital lobe, and we go longitudinally, and we cover the whole length of the hippocampus and the amygdala, or the direct temporal route, where we can just go through the temporal cortex and go into the mesial temporal structures. Again, there are advantages and disadvantages for both routes. I think that the Europeans prefer more the transtemporal route, the Americans more the occipito-temporal route. Again, there are advantages and disadvantages for each method, but I think finally at the bottom line, the surgeon is the one who decides which is the most preferable method for each surgeon and each patient. Sometimes you have to individualize your treatment based on the patient's pathology or the patient's anatomic variations. And of course, with the implantation of subdural electrodes, we can use any combination of grids or strips. We can practically cover any area that you can imagine. We can use interhemispheric subdural electrodes. We can use subtemporal electrodes because we want to cover the temporal pole, as you may see here. We want to cover the vicinity of the mesial temporal structures. We need to just have combinations. We can cut and we can connect. We can do pretty much whatever we want. You need to keep in mind that in the market nowadays, there are electrodes, subdural electrodes that are designed for special anatomical areas, such as the insula, or there are subdural electrodes that can cover in high resolution certain areas. So we can have hybrid electrodes that they have these contacts, the typical round contacts, but also microwire arrays in between the contacts. And this can provide significantly higher spatial resolution if we are in an area that we want to have some kind of more meticulous monitoring or more meticulous stimulation for mapping purposes, if we use that for mapping purposes. Having said that, you need to keep in mind that the implantation of all these electrodes, and especially the subdural electrodes, is associated with significant complications. This is the work that I had published with my mentor several years ago, and actually we summated our experience from the Medical College of Georgia. And you can see that hematomas, the occurrence was anywhere from 1 to 2%, brain edema, and this is referable mostly to the pediatric patients that we use bulky interhemispheric subdural electrodes, focal neurological deficits, in the vast majority of cases, transient deficits, anywhere from 1 to 2% infection, and also death in 1% of the cases because of increased intracranial pressure. So every time that you are planning to implant many electrodes, and especially bulky electrodes, interhemispheric electrodes, in pediatric patients, then you may consider inserting also an intracranial pressure monitor in these patients and have some kind of monitoring and try to identify if there is any kind of hypertension in these patients. The literature is pretty much in agreement with what we published from our experience, and you can see I was asked from the neurosurgery clinics of North America a few years back to just have some kind of meta-analysis on the incidence of subdural and depth electrode associated complications, and you can see that brain edema anywhere in the literature from 0.5 to 14%, the development of hematoma anywhere from 1 to 14%. Infection rate is anywhere from 2 to 17%, and this is totally associated with the duration of monitoring. In other words, the longer you keep your electrodes in, the higher the chance of having some kind of infection in these patients. And also the CSF leakage after implanting subdural electrodes in these patients, the incidence anywhere from 0 to 20%, but you need to keep in mind that in several surgical series, this is not considered as a complication, so the incidence of the CSF leakage may be definitely underreported. So another interesting thing is that by implanting electrodes in these patients, you may end up recording something that is non-typical. It's not the regular seizure activity of these patients. And this was occurring in approximately 3% of the reported series. And this is of special interest, especially if the epilepsy surgeon is a young and non-experienced surgeon. This may be a highly misleading finding. So you need to be very careful when you record. You need to record the typical seizure activity of the patient. Don't pay any attention to something that is not typical, is mostly related to some kind of microtrauma by implanting your electrode, your subdural electrode, or may be related to the development of some kind of hematoma, either subdural or epidural in these patients. Now, before closing that preoperative evaluation of these patients, I think that I need to spend a few minutes in the methods that we can use, we can employ for identifying the eloquent areas, the eloquent cortex in these patients. Is that of importance? Of course, because we need to know not only what we can remove, but also what we need to avoid when we do our surgical planning. And sometimes we need to be really aggressive and go to the proximity of functional, of eloquent cortical areas. So we need to have a really good, accurate reading of the cortical and the subcortical map of each patient. You need to keep in mind that the anatomical model, the anatomical knowledge for eloquency is not adequate for this patient, is not safe for this patient, because there is significant variation, and this is well described in the literature, not only from patient to patient, but interestingly enough, on the same patient from time to time. In other words, the Broca area or the Wernicke area may not be in the same anatomical area on the same patient at different times of his or her life, depending on the underlying pathology, depending on the patient's habits. So there is the concept that we currently use is that these areas are highly, how can I phrase that? These are networks that change all the time. And I think that one term that can be used and nicely describe that high variation is that of a cloud, which changes shapes all the time. And I think that we need to identify that and be able to securely avoid these areas on every single patient. So the methods that we use is the WADA test, the functional MRI, the magnetic source imaging, which is, as you may recall, the method that we use the magnetoencephalographic data when we superimpose those on the MRI, and also the intraoperative and or the extraoperative cortical stimulation. I'm talking about direct electrical cortical stimulation, and the high density EEG, the one that is surface EEG with 256 or 512 contacts. So let's see what each of these methods can provide to the evaluation and the cortical mapping of these patients. The WADA test, this is really, I would say that this is something that we have used more than any of the other methodologies. but unfortunately can easily lateralize the eloquency and the dominance on a patient, but cannot identify the area, the exact anatomical area that this eloquency is located. It's a clinical study, minimally invasive. The only problem with that is that during the last few years, there is some kind of a problem in the distribution of amobarbital around the world. There are certain countries that you can find amobarbital, other countries that you cannot find. For example, I know that in Europe, in the vast majority of the European countries, you cannot find amobarbital for some reason, and the same is in North America. But I don't know about the rest of the world. We can easily identify the dominance by employing a WADA test, and the only thing that you need is a neuropsychologist and an interventional neuroradiologist or an interventional radiologist to just perform cerebral angiography. What about fMRI? Non-invasive test, easily applicable with quite good spatial resolution, and if you just perform that along with diffusion tensor imaging, you can have significant information and quite accurate maps, cortical and subcortical, if you combine that with the DTI, about the area that we are planning to just surgically intervene. Now, the disadvantages is that you can have a really accurate localization of the sensory motor functions, but this is not the same for language functions. I would say that it would be a fair statement to say that the accuracy for language mapping is anywhere from 80 to 85%. Is that enough for a surgical intervention? I would say no. And also the problem with fMRI is that it's not apparently applicable to patients that cannot undergo conventional MRI, but also is not accurate in patients that there is the underlying pathology is a vascular abnormality, such as an AVM or an AVF, a fistula, or a cavernous malformation. So in these cases, there is no reason to just employ an fMRI for a cortical or subcortical mapping. And you need to keep in mind that the modality that we mostly use nowadays is the task-generated fMRI, but I think that we'll be able to get significant more information by the introduction of the resting state fMRI, which has become clinical routine in certain centers, and I'm looking forward to see if this can provide more information. The same is applicable for magnetic source imaging. The magnetoencephalography superimposed on an MRI can provide information, but the major disadvantage is that we do have really limited experience. This is considered a research method. And also you need to have that expensive equipment. We've already discussed about that. And the other option for having some kind of accurate mapping is the extraoperative cortical stimulation and mapping. Of course, the intraoperative is something that you can perform in the OR with a stimulus, electrical stimulus, which can apply directly to the cortex, and you can use bipolar or monopolar stimulation, but you can do the same thing extraoperatively when you implant your subdural electrodes for monitoring purposes, for EEG monitoring purposes. Then you can use these same electrodes immediately after you finish your monitoring period, your seizure monitoring period. You can use them as areas for stimulation and mapping. Now, there are certain advantages compared to the intraoperative stimulation and mapping, and disadvantages. And I think that the major disadvantage of this extraoperative stimulation and mapping via subdural electrodes is the fact that you cannot perform a subcortical mapping unless you have implanted depth electrodes in these patients. And when you do that, you need to have multiple depth electrodes. So I think that with that, we are going back to our algorithm, and you can see that we have moved, and we are with the vast majority of these patients in that group, in the surgical intervention group. In other words, there are very few patients after that exhaustive preoperative workup that we cannot identify an epileptogenic network, or we can identify an epileptogenic network, but we cannot resect it, or we cannot modify it. So I think that to wrap it up, the preoperative evaluation is of great importance for these patients. And although the neurosurgeon is not the one who's actively involved on every single aspect of this, on every single method of this preoperative evaluation, I think that he needs to coordinate the whole process, and he needs to be able to identify the accuracy of each method so he can critically evaluate the quality of information that he gets in order to have the safest planning of his surgical intervention. And I think that I'll stop here, and I would like to say a word to the memory of my beloved mentor, Joseph Smith, who was my mentor, but a good friend, and also, I would say, a scientific father for me. And I'll be more than glad to answer any questions you may have. Thank you so much.
Can you hear me?
Yes, we can now. Yeah.
Sorry. So I just want to say thank you, Professor. This was a fantastic talk, and really a walk through how you and how others think about, taking a patient who is struggling with epilepsy and really moving them towards seizure freedom. As you point out, it's some parts that are algorithmic, and a lot of it comes with just experience and taking it case by case. One thing you just mentioned was kind of the close connection and working with the neurologists, the nursing throughout this, and many of these take a very complex and sophisticated communication system. What time point do you typically meet the patient, or when do the neurologists get you involved to start counseling about taking that next step towards depth electrodes or more invasive approaches?
If you were asking the same question when I was in the States, the answer would be totally different. But practicing in Greece nowadays, it's interesting because I meet the patient early after the evaluation by the epileptologist. So most of the time, I see the patient going through the imaging protocol. I discuss with the neuroradiologist, and most of the time I have to direct the patient to the right imaging center, discuss with a neuroradiologist, try to make him understand what exactly I want to see on this patient, because it's not a rare event to see somebody coming with 3 or 4 MRIs and having negative MRI studies, but none of them was a proper MRI study. Mm-hmm. So I think that if you practice in an area or in a country that there is not an established epilepsy surgery program, then the neurosurgeon needs to take over and try to coordinate all the other physicians, the epileptologist, the neuroradiologist, the neuropsychologist, the nuclear medicine physician, even the neuropathologist after resecting, the tumor. So to answer your question, I see the patients from the beginning. Mm-hmm. Immediately after the epileptologist. So when my epileptologist says, okay, I have evaluated this patient and I think that this may be a surgical candidate because of this and this and that, then I get involved. And I'm trying to discuss with every other partner in that group. And most of the time, we are trying to have these epilepsy board meetings, which is not easy, especially if you have people that are not located in the same facility. Mm-hmm. So, and I think that this is a common problem in areas that there is not an established epilepsy surgery program, or if you use people that are in satellite institutions, for example, your neuroradiologist is on an outpatient imaging center or whatever.
Very good. So I want to remind the participants you're able to write your questions into the chat or the question and answer box, and we'll read them aloud. So we have Thanasis Pischalis asking a question. Regarding the underutilization of epilepsy surgery, do you think it is a primary health problem, or are there concerns from specialists and awareness too?
I don't have a clear answer to that question. Actually, it's something that it's a challenging question for me after all these years and after practicing both continents, in the US and here in Europe. I think that part of the problem is the way that we neurosurgeons approach these patients. In other words, when we start talking to these patients, I think that we're trying to be very meticulous about the potential complications and from epilepsy surgery, and especially in patients that are neurologically intact. This is quite a scary introduction. So I think that this is one problem. The other problem is that we are not really frank with publishing our complications. So there are cases that are presented by neurologists or primary care physicians that they say, okay, this patient had medically-intractable epilepsy, underwent surgery, and now he does have a major deficit. I think that we need to be very meticulous about discussing in a patient-friendly way all the potential complications. We need to establish some kind of communication with the referring neurologist and general practitioners, and I think that we neurosurgeons need to spend a lot of time discussing with general practitioners, because these are the physicians, the primary care physicians see these patients in many countries. And also trying to convince the neurologists that we can do a really good job by just resecting that epileptogenic network or epileptogenic focus. I think that this is just part of the problem, because if we go to a specific situation, for example, in my country, I think part of the problem of the underutilization is related to the fact that these patients cannot easily get into the system, and when they get into the system, insurance problems, going from place to place for completing their preoperative evaluation. When they finally reach the position to a situation that they are good surgical candidates and the decision has been made, then they have to wait 6, 8, 10, maybe more months for undergoing surgery, and they get tired, of course. I think this is just a few reasons for that underutilization. Now, having said all this, there is still underutilization of epilepsy surgery even in the States, where theoretically there are epilepsy surgery programs running for many decades, and I don't have a clear answer to that question, but I'll be more than glad to share any thoughts from the audience regarding this issue.
Yeah, Thanasis, I allowed you to talk, so if you want to unmute yourself, you can follow up on that.
Yeah. Good morning. Thanks for the wonderful talk, Professor, as always. One other thing that, because I think you hold some annual meetings on epilepsy surgery, then Larissa agrees. It's one of what Mr. Sile used to talk to me, to say some kind of ethical issues about people not being able to accept how resecting, let's say, in brackets, normal brain tissue would make them having a better quality of life, or making them seizure-free, and actually let them begin again. So there is also a lot of prejudice in society and primary health physicians regarding how helpful would that be, or how can we help these patients, since medical pathway does not really help.
I totally agree, Thanos. But you need to keep in mind that this theoretically normal brain is not normal. That's why the patient comes to us. And it's not that there is some kind of a minor abnormality in that area. There is a major pathology in that area, and the patient cannot have any quality of life. You know, the vast majority of these patients are having multiple seizures on a daily basis. So practically, they don't have a quality of life, but they are not safe too. They're not safe for themselves, they're not safe for their families, they're not safe for the society. So I think that we need to just somehow we need to convince, as neurosurgeons, other specialties and also the community that epilepsy surgery, whenever is applicable, is a great opportunity for these patients to significantly improve the quality of their lives.
Very good. Let's see. We had another question about what predictors do you feel would be most predictive of postoperative memory impairment in temporal lobe surgery?
I think that we'll cover that in the next presentation, next Saturday's presentation, where we'll talk about surgical treatment options. I think that I would say the duration of epilepsy, before the surgical intervention may play a role. The extent of the surgical resection may play a role, and also the laterality may play a role. In other words, it's different if you are working on the dominant hemisphere versus the non-dominant hemisphere regarding memory. And I think that that's another part of the problem that we were discussing a few minutes ago about the underutilization of epilepsy surgery. The fact that we, as surgeons, we hadn't identified all these complications which were associated with neurocognitive performance of these patients. In other words, the memory was something that recently we started discussing about as a potential complication. Also, personality changes or other psychiatric disorders that occur either de novo or they become worse after surgical intervention. And I think that if we sincerely start reporting all these complications, then we may be more convincing. But I'll be able to just come in detail during next week's talk about all these prognostic factors for temporal cases.
Good. Dr. Thango, would you like to ask a question?
Sure, Prof, that was an excellent talk. Thank you so much. And in countries that see quite a lot of epilepsy, and we sometimes find that our patients end up really being hogged by neurologists, I think it's really great having these type of talks from centers that have very well-established epilepsy centers. My question actually was answered. It was on video EEG. But I did think you broke it down a bit more, that you went from non-invasive to invasive. So when you do your cortical grids, do you still also have your patients on video EEG, or is it purely telemetry?
No, I do keep them on video EEG. I think it's easier, and it's definitely related to lower infection rates in these patients.
Thank you, Prof.
As a follow-up to that, I guess, when you're, some centers, and we've transitioned at Mass General to using the ROSA robot quite a bit, and the ease of it also facilitates placement of more and more leads. So how, when you're placing these leads for video EEG depth electrodes, decide how many to place, and then you kind of walk through the complications, and while they're overall rare, many of them are 1%. Do you keep these patients in more of an intensive care unit like setting throughout this time, or are they on the floor?
Okay, starting from the number of the contacts and the number of the leads that you want to use, I think that the epileptologists, if you discuss with epileptologists, they want more and more. They want to cover pretty much everything, but you need to keep in mind that in certain cases you cannot do that, or you can have so much information that actually you cannot take advantage of all that information. And I don't keep them in the ICU, I keep them on the floor. Mm-hmm. I think it's easier to handle. Nursing personnel in my institution are quite familiar with that, and we never had problems, so I don't keep them in the ICU.
Right. Can I just ask one question, if that's okay, Prof. Fountas? So I'm just screen sharing. This is a paper, I don't know if you can see it, but this is a paper by Kerry Vaughan and Key Park as a senior author, estimating the global volume of surgically treatable epilepsy and they estimated that possibly up to 1.4 million new cases arise per year. So these are surgically treatable cases potentially. And obviously the highest prevalence, as expected, would be found in Africa, Latin America, and then in Middle East and Latin America. So obviously, you know, mostly in countries which are around middle-income countries. The pathway is often very sophisticated in terms of the preoperative evaluation, etc. But is there any way of addressing this, you know, huge number of cases in low resource settings from the surgical perspective? Are there any options? I mean, are there any options for more basic testing, but which might be equally efficient, at least for some cases, maybe just focusing on temporal lobe cases?
Angelos, I think that that's what we are doing today, right? We're trying to just give life to that project of global neurosurgery. And I think one way to deal with that huge problem is to just train people that they'll be able to just do cases in their own countries. If we are trying somehow to just having people, experienced people to go there and do cases, that would be impossible. And we cannot convince people to utilize or overutilize epilepsy surgery since we are underutilizing it. So I think that one way to deal with that problem is to have fellows from low-income countries to just come to Europe or to the US or certain areas in Asia and try to just train them and properly train them to be able to participate not only in the surgical management. That's why I decided to just dedicate half of my presentation to the preoperative evaluation, because I think this is one of the major problems of that underutilization, because you do have a highly trained neurosurgeon who can perform all these resective procedures or disconnective procedures, and then goes to a country that there's not an epilepsy surgery program, and then he's trying to just identify surgical candidates. It's not easy. He's trying to convince the epileptologist it's not easy. He doesn't know how he can start an epilepsy surgery program. And I think that one way to do that is to having them trained not only in the surgical curriculum, but also in the preoperative evaluation, if you prefer, the neurological curriculum. That's one thing. The other thing is to try to identify those cases, as you said, the straightforward temporal cases. In other words, those cases that there is some kind of agreement between the basic electrophysiological studies, an Ictal EEG, and an imaging study. And if there is a concordance in that, then I think that you can move forward and safely resect the ipsilateral to the pathology temporal lobe with no problems. And in the vast majority of cases, you can have a very good outcome in these patients.
Very good. I have a more philosophical question. So many of us, many of the people watching are young neurosurgeons, many trainees who are deciding what to as they go through. What really drew you to functional neurosurgery and temporal lobe epilepsy?
Okay, I have to tell you that I have to admit, first of all, that I'm not that young. So when I decided to do functional neurosurgery was not that popular. As a matter of fact, I remember I was going to the ASSF, the American Society of Stereotactic and Functional Neurosurgery meetings, and there were not more than 50 people there. Something that made functional neurosurgery really popular is the introduction of neuromodulation. So I don't know what brought me into functional neurosurgery. I love, I love the work that I was seen by Joe Smith, my mentor, and I love the way that you could modify things in somebody's brain. And I think that this is something that we intervene to the functions, the brain functions and the quality of life with functional neurosurgery more than any other kind of neurosurgical subspecialty. So that was the reason. Nowadays, I think that most people are driven to functional neurosurgery because of the neuromodulation, because it's easy, it's very effective, and in certain countries is rewarding too, to perform functional neurosurgery. But I think that it's something that we need to just advertise more among young neurosurgeons, so we'll be able to attract bright fellows and we'll be able to move forward functional neurosurgery. And I think that we are in the right direction, because I see with great pleasure that functional neurosurgical chapters become larger and larger, both in WANS and the CNS and also in the EANS. And from what I learned, it's the same in Asia too. So.
Brilliant. So I want to thank you again for taking the time out of your day to discuss the first part of, well, it's 2 webinars, and really leading us through how to think about diagnostics and approaching surgery for epilepsy. Do you want to give a quick line about what you'll be talking about next week?
Okay, I'm going to discuss about surgical treatment options for temporal and extratemporal, and I'm going to present data not only on resective procedures, not on the typical mesial temporal lobectomy, amygdalo-hippocampectomy, but also about non-resective procedures, neuromodulative and other options. And I would like to thank you both, Faith and Angelos, for all your assistance and your kind invitation. I really enjoyed it.
Very good. So we'll look forward to that. This will be uploaded to YouTube shortly, and we'll start advertising for next week's talk. Same time.
Thank you so much.
Thank you.
Thank you very much. Looking forward to next week. See you.
Okay. Thanks.